Okay, welcome everyone to the Choosing Wisely May webinar. Thanks for coming. Firstly, I'd like to begin by acknowledging the traditional owners of the land that we're all dialing in from today. Pay my respect to the elders, past, present, and emerging as well. So I'm delighted to hand over to Dr. Fiona Taverner, who is from Women's and Children's Hospital in Adelaide, one of our champion health services, and she's presenting on her Fast Feed and Wrap project, which has won a couple of awards as well. Thanks, Fiona.
Hi, thanks very much for having me today. I wanted to talk about the Fast Feed and Wrap project. It's a project involving infants who require insertion of a PICC line or peripherally inserted central catheter. By definition, babies who need PICC lines are generally unwell, and the most common reasons that they'll need a PICC line are for complex children having multiple medications administered, if they're requiring total parenteral nutrition, or if they require long-term IV antibiotics. So in our hospital, Women's and Children's, the way we'd always done it to insert a PICC line for these babies was a general anaesthetic. And my understanding was that that was what had always been done and would continue to be done. But one day when I was a fellow, I had what I'd call a light bulb case. It was a little baby who was really sick that I thought would really, really not do well having a general anaesthetic to have his PICC line inserted. And in fact, he was so unwell that I thought he would probably end up intubated in intensive care after such a simple procedure as having a PICC line inserted. And I really didn't think that this was appropriate. So I thought about it and I couldn't really think of a solution. I went to the radiology nurse and I spoke to her and I said, what is it that we can do to try and safely have this baby's PICC line inserted? And she just said, well, why don't we try a fast feed and wrap? And I was like, I don't even know what you're talking about. And she said that she would give it a go and try and do this baby's PICC line under local anaesthetic with him fasted, fed, and then wrapped to keep him comfortable. He's really successfully had his PICC line inserted without a general anaesthetic. And then it made me think, if we can do this for such a sick little baby, why aren't we doing this all the time to avoid these babies having a general anaesthetic? And therefore, the Fast Feed and Wrap project began. It was a joint collaborative between the anaesthesia department to not anaesthetise the babies, radiology department to insert the PICC lines with the Fast Feed and Wrap technique. I'm going to play a short video which was produced for the Women's and Children's Hospital Network Awards, and will hopefully give you a bit more information about the project. So the Fast Feed and Wrap project is inserting peripherally inserted central catheters, PICC lines, into newborn babies without a general anaesthetic. So we do this in order to avoid the complications and potential risks of a general anaesthetic in newborn babies who are really vulnerable and high risk. The baby's fasted for 4 hours and kept awake so that it's a little bit hungry. Then it's brought down to radiology. Local anaesthetic is applied where the PICC line is going to be inserted. And then the baby's fed and wrapped up so that they will then fall into a natural sleep while the PICC line's inserted.
The major impact that we've had is that we've avoided a general anaesthetic in children, and it's usually much easier for the child to recover after the fast feed and wrap than from a recovery point of view associated with the general anaesthetic.
I'm really passionate about the Fast Feed and Wrap project because I think it was a really great intervention to improve outcomes for newborn babies, but I'm really proud of it also because of the collaboration that we were able to achieve between the anaesthetic and radiology departments. So after we had the idea, I suppose we could have just after that particularly sick little baby gone back to doing all the other babies with a general anaesthetic. But as I said, I felt like we'd potentially stumbled on a better way of doing things. And so rather, I wanted to kind of really run with that idea. And so we had a rollout of a period of 6 months where we developed a plan for a fast feed and wrap process formally, including making documentation for the process, considering how we would manage failures of the technique so that the babies can still be looked after, their PICC lines inserted, such as a guarantee that they would go on the next suitable emergency list slot. We appropriately engaged all of the stakeholders who would be involved in managing these babies to both brainstorm ideas and then disseminate information for how the practice change would occur. And I think it's really important throughout the whole process is communication. Then we went through a period of change in practice over from a general anaesthetic to the fast feed and wrap technique. What I thought was really important to do after the period of changing practice was to close the loop. And what I thought was a good idea, I wanted to find out if it actually really was a good idea. So 12 months after starting the change of practice, I went back and had a look at what had happened. And essentially there were 9 babies over that period who had an attempt at a PICC line insertion using a fast feed and wrap technique. And essentially 8 of 9 of them were successful. And so 8 babies during that period avoided having a general anaesthetic. I appreciate that small numbers, but for me, improving the outcomes of every individual baby is really important. And over the years, and if it's done at other hospitals, those numbers can certainly compound. I also did write or publish a poster, which I presented at the Society of Paediatric Anaesthesia conference in Perth in 2017. So then to further close the loop, we actually re-audited nearly 4 years later and had a look at what was happening over that period. We hadn't heard of any particular concerns or problems, but just wanted to get a bigger look at how things were going. And we found that of 43 babies that were attempted to have their PICC line inserted, 42 were successful. So pretty close to 100% success rate. The one baby that didn't have success didn't go on to have a general anaesthetic and was managed with peripheral IVs alone. We're looking at fairly small babies of an average age of 35 days, with a quarter of them being preemies, 3.8 kilos on average. And so the conclusion of the audit was that babies under 6 months and under 5.5 kilos can successfully be managed with a fast feed and wrap technique without a general anaesthetic for PICC line insertion. And it worked out to be about 10 to 12 babies a year that are avoiding a general anaesthetic at the Women's and Children's Hospital alone. We did have it published in Paediatric Anaesthesia Journal in 2020. So then what were the other outcomes of the project? So far, we won an award, the Women's and Children's Hospital Network Award in 2021 and the South Australian Health Awards in the same year in the Enhancing Hospital Care category. Other important outcomes have been collaboration and increasing teamwork between the radiology and paediatric anaesthesia departments, which has been really fantastic and I think flowed on to other areas of work and projects that we do. And there's a lot of personal satisfaction that comes out of changing the way we do, and that these things can impact many, many patients, particularly if you can disseminate the information and potentially change practice in other places as well. So I just wanted to reflect on implementing a new practice in general and what the key steps were. Because for me, this was actually a fairly small project that just came from a small idea, a concern about an individual patient and a conversation with somebody else from a different craft group to come up with an idea of a different way of doing things. So if you identify a problem or think about a potential solution, then what do you need to do in order to change your practice? You need to go through a brainstorming process, considering how you're going to implement the change of practice, and really importantly, identify what the barriers are going to be into changing your practice, or what problems you may face along the way, what roadblocks you'll get. Engage key stakeholders, particularly in the brainstorming process and particularly in identifying barriers. These people will give you ideas about how to do things differently and will give you a different perspective on both how to do things better and what barriers you may face along the way. I put in here, don't forget the hidden stakeholders. So for us in this PICC line project, the important or the obvious ones, so I shouldn't say the important ones, were the anaesthetists who had previously been involved and were trying to not be involved in PICC line insertions. The radiology department are really obvious because they're the team that we're going to be inserting the PICC lines. But the important stakeholders for us also included the ward nurses, because they were the ones that were prepping the babies before they came down for the procedure. They were the ones that were making sure the babies were fasted properly. They were the ones that needed to be educated on how to apply EMLA to the baby's arm in the correct way, in the correct dose, and at the correct time to ensure that the Fast Feed and Wrap project was going to be successful. Communication all along the way is key. Verbally communicating with your the other people involved in your team, peripheral to the team, and including written communication and writing up manuals and processes of how to do things. During your implementation phase, being really mindful of being aware of if any problems are occurring, listening to what people are saying, and thinking about how you can improve things along the way will ensure that your implementation phase is successful. And once you've implemented a new practice, I think it's really important to close the loop. Whether it's by a formal audit, evaluation, surveys, just walking around asking people what's going on is a great way to start. But if you can do a formal audit, produce some real data and some real numbers to prove that what you're doing is actually working or making a difference to someone, that's really, really valuable. Once you've closed the loop, I think it's really important to also disseminate the information that you have, whether that be at department meetings, at newsletters, webinars, conferences. Those things are all really important. Presenting at posters at a conference or doing an oral presentation can be great for disseminating the information and also increasing the profile of yourself and your department or your team. If the project lends itself to it, again, writing the article up for publication is a really important tool in order to disseminate your information, share your ideas, and allow other people to benefit from the work that you've done. I've also mentioned media, something that I've become a little bit more aware of lately. In our hospital, we have a media department, which I never knew existed. They have the ability to share information that we're doing on their Facebook pages with the Women's and Children's Hospital Network Foundation. They also have the ability where it's appropriate to share information with our local newspaper media and television. So if your project is something that might be interesting to the public as well, if you can get your local media service involved, I think that's a really nice way to share your information and share what you're doing. If you don't work in a department or a hospital where you have a media service, you can always contact your local newspapers or other Facebook groups directly to try and disseminate your information. So just overall, the learning points that I've come away from this project is that if you see a way to make things better for your patients, your colleagues, your department, follow through, ask the questions. And you might not actually be able to do what it is yourself to make things better, as it was in my case. I couldn't do the PICC line insertion with a Fast Feed and Wrap, but I could ask someone who could. So if you can't do it, ask someone who can, develop a team, and learn the value of teamwork and collaboration to improving patient care. I put consumer engagement here because it's been a learning point for me that not from this project, but subsequently, that consumer engagement is really important. Don't actually really like the term consumer engagement because I like to look after patients and their families, but consumer engagement is the buzzword. I do think it is important to have consumer engagement. I didn't use any at all for this project. So while I think it's a really good idea that PICC lines are inserted in little babies without them having a general anaesthetic, I don't actually know whether that's what's important to parents of these tiny babies. I'm pretty sure if I asked, they'd be happy with it. But I think moving forward, it's really important to utilise consumer engagement with your projects. One, to make sure that the goals that we're trying to meet of improving patient outcomes or improving efficiency of the service or saving money, whatever it is that we're trying to do, we also want to know that we're actually meeting the goals of patients and their families, because they may not actually always align, and we don't know that until we ask the question. But I certainly know that also that consumer engagement is becoming a much bigger focus, particularly if you're looking at things like applying for grants for research projects. It may not be essential, but it's certainly a highly valued part of your grant application if you have a consumer advisor or consumer engagement built into your project. So if you don't do it already, I would encourage you to consider consumer engagement moving forward. And it's really important just to consider that even the little things that we do can make a difference for all our patients. And in my case, that's for our little people. And each one of these little guys, I think, really matters. And if you can have that focus moving forward, I think that's a really nice way to go about your practice. So just to finish off, I'd like to thank all the patients and their families that were involved in the Fast Feed and Wrap project, and a couple of people in our Department of Children's Anaesthesia and Radiology. And thank you very much to Choosing Wisely for asking me to present about my project today.
Thanks, Fiona. That was a great presentation and a really good example of challenging the way things have always been done, which is what Choosing Wisely is all about. So thank you for sharing. You can stop sharing your screen, and if anybody has any questions, please feel free to pop them in the chat. I think there's one there.
Yeah, so Deb has just commented the best solutions are from experience, observed problem and determination to solve it for one patient. Yeah, I think that's a nice comment to make before I go on to the question, is that, you know, you kind of go along doing what you're always doing because it seems to be okay. And even though you know that little babies have a high risk of complications having a general anaesthetic, we didn't have any major problems until I came across this baby that I thought was really not going to go well. And then you determine to solve it for that one patient, gives you the light bulb idea that might actually help a lot of other patients along the way. She's then gone on to say, is ultrasound assisted the default or any other methods used, site or vein finders? So in our particular hospital, I believe we have a relatively unique PIC service in that all of our PIC lines are inserted by interventional radiology team, which includes radiologists and highly trained PIC line nurses. So the anaesthetists in our hospital don't routinely put in the PIC lines. They are usually done in the interventional radiology suite, and they use ultrasound to find and insert the PIC line, and then use chest x-ray to check the location of the lines. So I think that the success of doing PIC lines in little babies without them being anaesthetised may also hinge on the highly specialised skill set of the interventional radiologists and nurses that insert them.
Thanks for the question, Deb. And we have one from Jess Shepherd there for you, Fiona.
So Jess has said, what were some of the barriers you faced when implementing this project, and were people largely supportive? Yeah, it's interesting. We didn't really have a lot of barriers. I was very reluctant because I was an anaesthetist and basically going and asking all of the radiology team if they could do the work without us. And I was really worried that suggesting that might be problematic. But that's making assumptions that you don't know what the goals or priorities are for other teams. So in fact, the radiology team were really supportive of taking on the project, and for a different reason to what I expected, which was that previously all these babies had to be booked onto an emergency waiting list, and then basically the timing of the PIC line insertion was dependent on when the anaesthetist and the emergency anaesthetic team was available to insert the PIC line. So without having to have an anaesthetic team involved, they could then take control of when the PIC line insertion occurred. And so for that reason, I think possibly alone they may have had really a higher level of support and uptake than I had previously considered they would have. There was a few people that were concerned about making sure that we had a backup plan if we weren't successful. Obviously, we then fed a baby who was trying to have a PIC line inserted. If they were fed and then the PIC line was unsuccessful, how are we going to manage that? So we just had to put in place making sure that we had a good plan for having them backed up on the emergency list for the following day when they could be refasted, and then also ensuring that they weren't then waiting a long time, that they missed out on their spot because they'd been fed previously. So I think part of that about the barriers was just going in and having really early, clear communication with people, finding out what problems may exist and trying to overcome those. But yeah, they were a lot more supportive than I thought they'd be, actually.
That's always good news.
Yeah.
Can you comment a little bit about how you were able to sustain the project, because you saw some really good results over at least a 4-year period?
Yeah, to be honest, it's interesting, I suppose, isn't it? When you start something new, it becomes what you think is a change of practice. What happens over time, whether that practice will continue or people will just go back to the way they'd always done things. To be honest, I didn't have a lot. While I was a champion really early on in making sure the project worked, after it was up and running, I actually didn't work in the hospital for a couple of years. So I certainly wasn't overseeing and making sure things kept going. I just really left it to its own devices. And I think the reason that it was successful was because for a couple of reasons, and not just one. So better patient outcomes is really important, and you'd like to say that that would be the only reason things would continue, but I don't think that's true. I think in this situation it was because there were other advantages, particularly for the radiology department, in being able to determine their own lists, work out by themselves when they looked after these babies, and not being dependent on the anaesthetic team on an emergency waiting list. So I do think it was a combination of better patient outcomes, which everyone could clearly see and were really supportive of, but also the pragmatic reasons of timing, convenience for the radiology team, who were the key stakeholders really once the project moved beyond having a general anaesthetic.
Thanks, Fiona. And then we've just got a nice comment from Deb Robbins in the chat as well.
Yeah, which is really lovely. Thank you, Deb.
Any other questions for Fiona before we wrap up? Okay, thanks so much again. And yeah, definitely, I'm sure if you interviewed all those parents, they would definitely be happy with the outcomes of your project. Yeah, thanks for sharing your work.
Thank you very much. Thanks for having me today. Much appreciated.